Welcome everybody. We'd like to take the next few minutes to explain some subtleties with calculating the heart score, as well as to give 3 example cases of how a heart score was calculated, as well as recommendations for disposition with those patients. With me today are Dr. Barbara Bacchus, who is an emergency medicine physician in the Netherlands, who is the lead author on the heart score study, as well as Dr. Eric Hess, who is world's expert and very prolific author with the use of shared decision-making, with specifically the use of chest pain choice with evaluation and disposition for chest pain patients in the emergency department.
Excellent. Thanks for the introduction. It's great to be able to connect with you here. And what we'll be doing now is discussing a few different cases, and I'll start with the first case. So this first case is a 40-year-old female, and she presents to the emergency department with left-sided chest pain that she describes as a pressure sensation. It radiates down her left arm, and it's also worse with inspiration. Her initial ECG doesn't show any signs of ischemia, and her initial troponin is less than the 99th percentile. Her only cardiac risk factor is smoking. So how would you calculate her heart score?
Well, if I would calculate a heart score for this patient, I would give a 1 for her history. It has typical as well as atypical elements. Her EKG upon arrival is negative for ischemia, so I would score 0 for her EKG. She's 40 years old, so that means 0 points for her age. She's a smoker, so that will give her 1 point for her risk factors, and her troponin upon arrival is negative, so that means 0 points for troponin as well. So then we end up with a heart score of 2. Now I wonder, Michael, how would you treat such a patient at the emergency department?
So we know she's in the low risk category for heart score with a score of 2. I would certainly, with that pleuritic pain, want to consider some other non-ACS causes, such as pulmonary embolism. But if I could rule that out based on either the PERC rule or maybe even a D-dimer, and I do have assurance based on some further testing, for example, troponin, that the patient is not having a MI, well, that would be the perfect patient for further evaluation as an outpatient.
I totally agree with you. I would also send this patient home from the emergency department after excluding other serious causes. I would ask her that if the pain comes back again, that she would call her primary physician or visit an outpatient follow-up at the cardiac clinic. Then I think it's also important to emphasize to this patient that if the pain gets any different or worse than what she has explained to me right now at the emergency department, then she definitely has to call her primary care physician or come back to the emergency department so we can check her up again. What do you think, Eric?
I agree with you. I think with the one caveat that if this patient didn't have any available outpatient follow-up, I might want to observe her a bit longer before I immediately discharged her. In that case, I would certainly get a serial troponin before I made that decision, but provided that there was outpatient follow-up available, I would discharge this patient as well.
Okay. Let me present you another case. We now see an approximately 50-year-old male with left-sided oppressive chest pain. It started when he was walking out the dog, and when he came home, he sat on his couch and the pain got away slowly. He had similar chest pain last week when he was riding his bike. This afternoon he was feeling a little bit nauseous, but he did not vomit. And well, he's now at the emergency department and the pain is gone and he feels actually quite fine. He's using tablets for hypertension. He got them from his general practitioner. His vital signs at the emergency department look fine, and his EKG right now is normal. You actually have done a second EKG to reassure yourself that there are no abnormalities or no ST elevation evolving during his stay at the emergency department. So when I calculate a heart score for this patient, I think each of you would agree with me that this is a history that is very likely for unstable angina. So I would score this as a 2 for the history. His EKG at the emergency department is normal, non-ischemic, so that's 0 for the EKG. This guy is 50 years old, so that means 1.4 age. He uses tablets for hypertension, so that means 1 risk factor, so 1 point for the R. And his troponin upon arrival just comes back and it's below the 99th percentile, so that means 0 point for his troponin. So we end up with a heart score of 4, but I'm still a little bit concerned about this patient with his very specific history. Eric, how would you treat this patient?
I think one thing to keep in mind is how powerful the troponin is as a predictor of safety. So if his first troponin's negative and I obtained another troponin as a serial troponin to ensure that he does not have an acute myocardial infarction, I wouldn't be worried that he would have an arrhythmia in the meantime, provided that he didn't go out and continue to exert himself. But this type of patient, I think, really does need further evaluation, perhaps consideration of stress testing, and if his symptoms do represent unstable angina, he may end up with a stent in place for symptomatic reasons. But I think it's actually an ideal pathway to have this occur in the outpatient setting. So if I was in a health system where the patient could be seen in the clinic in the next 1 to 3 days, I would be comfortable with him being seen in the clinic. But at this point, I would likely make sure he's referred to a cardiologist who would have the ability to both obtain the stress test and to consider intervention. And I would also explore with this patient what is his ability to make it to this appointment. Does he have a car? Does he have family support and such to make it to that appointment? This is also a patient that I would engage in a shared decision, so I would show him what his risk is using our decision aid, and I would simultaneously show him what all the management options are. If there's some reason that he's not able to make it as an outpatient, I would be comfortable admitting him for observation and consideration of stress testing. And then after walking him through these various options, I also would feel comfortable being confidently saying, I'm really worried about your symptoms. I really need to be reassured by you that you're going to make it to this appointment if that's your choice. And so if we develop this degree of trust amongst each other, I'd be comfortable letting him go. And if for some other reason, I would also be comfortable admitting him to the hospital.
Yeah. Do you agree, Michael? What's your idea?
Yeah, this is all predicated on the fact that the patient can follow up and does have access and desire to follow up. But if he can, the question isn't, does he need further evaluation? Because it's pretty clear that he does. The question is just, what's the safest way to proceed with that further evaluation, whether it's as an inpatient or whether it's as an outpatient with an expedited evaluation. I also would feel comfortable presenting those two options to him. If he asks for guidance, I might even encourage the outpatient follow-up with this patient. But I think both of those are reasonable alternative pathways to proceed with this patient.
Okay. I have another case to present to you. Because now we see a 67-year-old male at the emergency department, and he's been having some oppressive chest pain. It's middle left-sided. It does not radiate, but it's an awkward feeling. It lasted for a few minutes, and he's been having it last week when he was climbing the stairs. He has had a myocardial infarction 10 years ago, but that was so long ago he cannot clearly remember whether or not the symptoms are the same. And he's a little bit worried. He's feeling fine right now, so he's mainly coming in because of his previous history of myocardial infarction. When you look at his vital signs and your physical examination, you see that his blood pressure is a little bit higher, but furthermore, you see no abnormalities and no concerning signs. His EKG at this point is normal, and you've even compared it to his older EKG, and you see no ischemic changes. And his troponin just comes back, and it's 0.012, so that's again below the 99th percentile for a high-sensitive troponin. If I would calculate a heart score for this patient, I think I would give it a 1 for the history. So there are typical as well as atypical elements, and it's not clearly unstable angina. His EKG shows no abnormalities, so that would score a 0. He scores 2 points for the age, since he's 67 years old, and he scores 2 points for his risk factors because he has had a previous history of myocardial infarction 10 years ago. And his troponin is below the 99th percentile, so that scores a 0. So then we end up with a heart score of 5 for this 67-year-old patient. Michael, how do you treat this patient?
So it's interesting that we actually give that patient 2 for the risk factors, and I think that's a subtlety with the heart score, that when you think of risk factors, if the patient already has had an MI, he's already at the highest risk level, of course. So that's a subtlety that's important to remember, that if you do have a history of MI or some sort of peripheral arterial disease or cerebrovascular disease, you get a 2 automatically. So that's something important to remember. But as far as this patient having a 5, based on the fact that he is over the age of 65, he automatically has 2 for that. So unless we're willing to say that we are going to admit all moderate risk patients, which then would say that almost everyone over the age of 65 with at least one risk factor and a concerning history would be in that category, we still need to use our clinical acumen, to use our bedside judgment with that patient. He scores a 5. I'm going to treat this guy very similar to the last patient. I'm going to say, yes, we need further evaluation, but again, it doesn't need to happen in the hospital. So we think about some of those risks to hospitalization, things like sundowners with hospital falls and brain bleeds or hip fractures, things like DVTs and PE or pneumonia, MRSA infections, C. diff, false positive tests, even the expense and hassle of being admitted. Admitting that patient might be easier for us, but it's not necessarily what's best for the patient.
And I would agree with that, Mike. And as Barbara was presenting the case, this is a type of patient who gets the majority of his elements of the heart score purely based on comorbidities that he would have just walking around the street. Mm-hmm. And so his actual history of the present illness doesn't make me concerned. So unlike the previous patient, in which the history of the present illness made me very concerned that he actually had to have follow-up, or I wouldn't have felt like I was providing good medicine, this patient, I would be comfortable with him either coming in for further observation or being discharged, and probably we wouldn't have the same degree of concern as I would the previous patient.
Yeah.
I'll present sort of an inane sort of extension even of this patient. 67-year-old man, history of MI, so he's at 4 already, walking down the street, gets hit in the chest by a baseball. Obviously not cardiac, or else it'd be extremely strange and unlikely coincidence. He is still moderate risk and he has chest pain. So we have to use our bedside judgment with that patient. And we have to do that in a patient-centric way.
Excellent.
I totally agree. So thank you so much. Thank you for joining me. I hope that we've given you a little bit more insight into how we calculate our heart score and how you can use that at the bedside to treat your chest pain patients, how you can use shared decision making, and how you have to weigh the risk of admitting your patient or do an outpatient follow-up.
Thanks, Barbara.